My name's Ash Kapoor. I'm the medical director at Levitas Group and also CEO of Levitas One. Levitas One being our collaborative arm where we look for like-minded individuals or those interested in high-level innovation with a view to supporting well-being and health beyond disease, really, is the term we would use. So I'd like to introduce Dr. Mike Hickman, a consultant cardiologist, and we're going to be talking a little bit about heart attacks and what we can do about stopping them. So Mike, I'll just like you to introduce yourself and then we'll have a little conversation.
Well, thanks, Ash. It's great to have the opportunity to speak with you and your patients this way today. It's always a privilege to be able to put over some of my sort of key subjects to my audience. And my great interest is really trying to get a grip on sudden cardiac death and trying to reduce the amount of our patients who drop dead unexpectedly of heart attacks. We have had a real recognition, I suppose, in the last 10 or 15 years that we really tackled quite a lot of this disease 20, 25 years ago, but we've stagnated in the last 10 to 15 years. And that's because of all of our aims for our treatment were towards finding people with angina, pain in their chest when they were doing things or exerting themselves, and then identifying whether they had heart disease and whether they needed stents or bypass or what have you. What we unfortunately missed with that is that most people have heart attacks without warning. And the work I've been doing, and I'd like to discuss with you today, is how do we pick out those individuals who are at risk of having heart attack, and how then do we lower the numbers of this horrendous disease process that is happening all around us to people we all know.
Yeah. So what you're saying is that essentially we kind of can have things going on in us without even knowing about it. And the aim would be to progress into looking at those groups so they don't have the blockages, they don't have those sudden heart attacks. How do we predict this? Because if you haven't got any symptoms, how do you know you're not one of those people that might have this sudden heart attack?
Well, I mean, it's been difficult, and that's why we've struggled to date to make great progress with this. So we picked out the low-hanging fruit, those with symptoms, those with angina, but we could only really try and pick out people we thought might be at risk of heart attacks. And we had some good scientific evidence from the 1970s, 1980s, from big longitudinal studies where they followed up populations, and they worked out if you had high blood pressure, or if you had high cholesterol or diabetes or smoked, you might be at increased risk. And so historically, as you know, because it's been mainstay of our practices now for the last 20 years, is we've been trying to hit those risk factors. So we say, okay, get your cholesterol down, diet, eat less, lose weight, exercise more. But what we haven't been able to do is to understand actually on a personalized basis whether someone is genuinely at risk. And this is where things have changed now.
So what you're saying is that we can manage blood pressure, we can manage perhaps cholesterol, lifestyle to some extent, but we still don't really know.
Well, up until now, no. And so we were treating the population on using population science, which is the best we had on offer and the best we have for public health. But we weren't treating people personally. We weren't offering personalized medicine. We were making a judgment on an individual based on a population, rather than making a judgment on an individual based on that individual's health and what's been happening to them over the last 15 years.
I think that's the thing. Of course, when you have a national service, you've got to draw the line on what you can do and what you can't do. And population or prevalence-based medicine is limited in that respect because it doesn't take into context personal situations, a number of factors. And we believe, certainly at Levitas, that things happen everywhere in the body simultaneously. So, we can't just look at one isolated or 2, 3 isolated measures and come up with what I call a precision-based outcome. So what are you doing to change that? What is going on in the cardiology world to look at that risk?
Well, what we've done is, firstly, the ability to scan the heart arteries has absolutely changed in the last 10 years. And we scan the arteries using a CT scan with contrast, which is injected through a vein in the arm. And we get a really beautiful three-dimensional model of the heart arteries. And that will show up whether there's plaque or cholesterol deposition in those arteries, and whether there's calcium. And we can make, based on these scans that we've had available now for about 10 years, but been really good for about 5 years, we can really get a handle on whether that slightly high blood pressure or the slightly high normal cholesterol has actually resulted in problems with the arteries. So far, we've been able to get some diagnostic imaging, as we call it, methods whereby we can see proper images of the arteries, but without having to go inside like with angiograms that we have done historically.
But less invasive, much less invasive.
Yeah, less invasive, less costly, less unpleasant. Takes half an hour to an hour to get done, rather than in hospital for half a day, and extremely rare to have any side effects or complications. But the game changer now is AI, like with many things. And there have been some remarkable studies published in the last couple of years in the Lancet and other leading journals, showing various different tools that we are using now to further assess the data from these CT scans. The real game changer for us is looking at evidence of inflammation in the arteries. And as you and I know, inflammation can occur throughout the body and has quite a lot of deleterious effects depending on how it's occurring. But we can now measure changes in the fat surrounding the arteries, which evidence whether the plaque or the cholesterol, which is embedded in the wall of the arteries, is inflamed. And that is really important.
Right. So you kind of look at the artery using algorithms and AI, and you can pick up inflammatory fat on the outside, which gives an indicator of what's going on inside.
Yeah, the fat tissue on the outside of the arteries changes if there's inflammation in the arterial wall.
Yeah.
And if there's inflammation in the arterial wall and you score highly of having inflammation there, you are at many times greater risk of having a heart attack or death than if you have a low score. And what is really fascinating in some of these really large studies, where they follow up 40,000 patients for 3 years, where they've done these tests on, is that if you have coronary disease with no inflammation, your risk is relatively low. If you have coronary disease with inflammation, you have a 20 times higher risk of dying in the follow-up period.
Goodness, so, that's a massive increase.
It's remarkable. And
we're treating patients the same irrelevant at the moment.
Yeah, so what that allows you to do is, firstly, it allows you to pick up risk in those with coronary disease. The second component of this, which is even more interesting, is those with no obstructive coronary disease, bit of plaque, and inflammation are again at a 20-fold higher risk of heart attack. So of heart attack and cardiac death in the follow-up period. So the power of this technique, you can separate out in those of your patients who already have coronary plaque or might have had a stent a few years ago and on their statins and pills, scan them, and if their inflammation is low, you know that the treatment you got them on, the lifestyle measures the patients are undertaking is working. Scan them and it's high and they've got lots of inflammation and we need to do more. And the other things, we've got a lot of new medical pharmacological technology that's come through where we can do more, and there is more that can be offered.
And can I ask you, Mike, I mean, yes, we believe inflammation is the root cause of all diseases, whether it happens to the mitochondria in the cell, the tissue, the organ, it is the process. If you were to put interventions in, aggressive interventions, and rescan these individuals, do you note changes?
We are seeing that in the cohorts we've been doing. There are more longitudinal studies and outcome studies to be done with this Cariheart technology, and that work's been undertaken as we speak. But at the moment, from the patients that we are looking after and the patients we are utilizing this technology on, interventions are resulting in reduced risk scores and therefore reduced risk of cardiac death. But the longitudinal studies will take several years for that to come out.
And how long does it take for these inflammatory changes to reverse on the test itself, whether it has?
Yeah, that's a great question. And I suppose it depends on what is the cause of the inflammatory change. So the inflammation is going to be caused by poor cholesterol lipid control. It's going to be caused by poor glycemic control, so your blood sugars going up and down, not being able to get control of them. Some of us are prone to that by our genetics. Some of us are more protected. It'll be down to high blood pressure, hypertension, smoking, other inflammatory conditions, rheumatoid arthritis, for instance. And so all of those factors, depending, I suppose, on how easy they are to target and how easy the levers are to pull to try and correct those abnormalities, will depend, I assume, on the rate of reduction. This is work that's ongoing.
And in summary, I guess the more conditions you have that are inflammatory, the more longer it'll take, which makes sense completely. Yeah. But it's a hopeful story because it's reversible, which is the most important thing.
If one goes, without getting too technical, if one goes down and actually looks at what's going wrong in the arteries that causes these arteries to suddenly block and cause cardiac death, what it is the plaque, the cholesterol in the vessel wall, it becomes very inflamed, and you get macrophages go in, they cause inflammation, and lots of chemical messengers inflame in the vessel wall. And with that inflammatory process, the cap that separates the cholesterol from the blood flow inside the artery weakens. And then what happens? That weakened cap ruptures. And we call that plaque rupture. That's what gets us. And that's when you get a sudden clot form. Now, we know that getting the cholesterol down, having people on statins and other more modern drugs, we know that now we're looking at the Wegovy's and the Mounjaros, so we call them GLP-1 agonists. These drugs are reducing inflammation in the arterial wall. And what we see is the dangerous bit of cholesterol in the vessel wall diminishes, and we see the plaque, the fibrous cap thicken, and we see a down regulation of inflammation in the vessel. And as you get that fibrous cap thicken, that can be caused by statins, high intensity lifestyle changes, other drugs. And as we see that thicken, the risk of that plaque rupture goes and the risk of a heart attack diminishes. And so coronary disease, we may have lots of plaque in our arteries, but you can live to 100 with lots of plaque in your arteries. What kills you is the inflamed plaque and the plaque rupture. And that is what we can measure now.
Interesting. Well, that's a paradigm shift in thought, really, isn't it?
Yeah.
And something a lot of my patients will ask me is, I'll give you an example. You've got a fit 50-year-old, does all the right things, eats well, blood pressure's fine, cholesterol's normal. Should these people get this scan?
It's a very good question. And one has to look at pre-test probability. And I think one of the important factors here is family history. From the age of 50 and upwards, I think there is an increasing argument to use these scans if one is interested in promoting long-term cardiovascular health. One has to say that in the context of us awaiting large-scale data on using CT angiography, the actual CT scans, to screen a population, and that work is underway in 2 big studies currently. But I think on a personalized basis, with appropriate consent and discussion of your patients about what is involved and what data we're going to get and what you're going to do with that data, if it's going to change how you manage your patient, then absolutely, I think there's a very reasonable argument for offering one of these scans with a Cariheart assessment. But whether we start using it as a whole-scale screening technique will depend on further data that will come out down the track.
And I mean, clearly you're leading edge on this technology. How many centres in the UK do it?
We're the leading centre doing the Cariheart. I believe there are 2 or 3 other centres around the UK doing some of it, but I think at the moment we're the centre doing the most of
And
this.
if you could just talk me through the natural pathway for a patient. I see a patient, there are certain risk factors, they get referred to your centre. Tell me about the journey for the patient from the point that we refer to seeing you and your team.
Well, we try and make it easy, as you can imagine. We're trying to offer a pretty seamless service. We have a patient care coordinator who will be the primary person and generally the only person involved with that patient's process from the moment of phoning a patient to booking them through, making plans for to come in and have the scan done, discussing with them insurance and what have you that might need to be sorted out, and then being their primary point of contact for results and what have you. When the patient is booked in, they'll come into our scan centre, which is based in Guildford, just off the A3 in the Surrey Research Park, and they will be with us usually for a couple of hours. The scan is painless, except having a cannula, a drip put in one of the veins in the arm. Sometimes we have to give patients a little bit of a beta blocker, which is just designed to steady the heart down so we get a really nice crisp view of the heart, so it's not moving too quickly when we scan. The scan itself is comfortable. One can feel that one has a bit of a warm, funny flush going through one's body as the iodine contrast goes in. And the scan itself takes, in the whole of it, from the prep and the timing and the setup, takes about 20 minutes. We do ask our patients to stay with us for about half an hour afterwards. And depending on whether most people can drive home, that's fine. But if they feel a bit they feel a bit funny after the dye or something, we'd ask them to wait a bit longer, of course. It is very rare to have any problems with the procedure. Very rarely, theoretically, people can have an allergic reaction to the iodine contrast, and we would give medications to treat that should that happen. With the results, we'll get the results back to you within 2 to 3 days, and that'll allow you to discuss with your patients. And if you want your patient seen by us, of course, we're happy to help. Alternatively, then you might choose them to see their other more local cardiologists wherever they're based.
Fantastic. That sounds very streamlined. Excellent. And are there any patients who shouldn't have this scan?
We certainly don't scan young patients under the age of 40 unless they're giving us significant concerns that there may be symptoms. So it is rare but possible to have heart disease under 40, and certainly if someone's getting cardiac symptoms of concern or have very strong family histories, we make an exception, but generally under 40 is unusual. We wouldn't scan anyone pregnant, unless of course there was an overriding requirement for the safety of the individual, but usually a catheter angiogram is better in that case rather than a CT scan, and that would be done in a hospital environment. And we tend not we wouldn't want to repeat a scan on someone who's just already had a scan just for the sake of assessing with this technology. So but generally most patients where it is necessary and important to understand their coronary anatomy and coronary plaque, then they're not many contraindications. People who've had a significant allergy or severe allergy to contrast, as previously, we'd then probably look at a different way of assessing their arteries.
Fantastic. Well, this certainly seems to be a phenomenal innovation, and something that worries almost everybody. Heart attacks, strokes, and cancer are the 3 big things on people's minds. So this is a fascinating, investigation in the sense that it's very specific, focused, and predicts risk at a very, very, well, I say, logical way. And ultimately, there's no point doing a test if you can't do anything about it. But we now know there's lots you can do for inflammation. So from that perspective, it's a very positive finding in cardiology, isn't it?
Yeah, I mean, we're very excited by it, and I'm sure that everyone will be hearing a lot more about it. I know the NHS is starting to do larger studies on this through some of their centres, using the Cariheart technology, doing some research studies with it. But I think that it is a technology of its time, and it's important. And the ability, with the interventions you guys have to offer, which you're a specialist in, and plus some of the other new pharmacological interventions that can be offered. Yes, there's a lot that can be changed if we are seeing higher risk patients.
It's a very good hope story, and I think certainly our team at Levitas are very keen to work with your team to improve this sort of ability to predict what's going on and then do something about it. So thank you for joining us, and we'll probably be hearing much more about this, and I certainly know there's lots of my patients who'd be very interested.
Ash, great speaking with you, and thanks for your time.
Lovely. Take care.
Bye.
Bye.